Morning, good afternoon, and good evening to all our wonderful speakers, chairs, and audience all around the world. This is the first episode of the ACNS Skull Base Webinar that we're starting today. We have three wonderful speakers today. We'll start with Prof. Luigi Cavallo, who's from Naples, Italy, followed by Prof. Abuzair Gungar from Istanbul, followed by Prof. Hisae Mori from Osaka, Japan. So the chair for this webinar is our honorable guest, Professor Hiroki Morisaka from Osaka Metropolitan, Japan, and the discussion is Prof. Ashish Kumar from Canada. So we'll start, and I'll hand this podium over to Prof. Morisaka Sensei.
Yes, so good morning and good evening and good afternoon to everybody. So I'm deeply honored as the chair of the ACNS, this newly the Skull Base webinar. First, I will introduce the topic. So the first topic is the endoscopic and exoscopic approach will be presented by the Professor Cavallo, and the second topic is the interhemispheric approach by Professor from the Gungo, and finally the Professor Mori talked about the gamma knife treatment for the skull base meningioma. So at first, so Dr. Professor Cavallo, please. So let's start your lecture.
Okay, I will start to share my screen. Perfect. Thanks again for the invitation, and in the next 20 minutes, I will try to show you our experience with the use of the endoscope, but also with the exoscope for the management of anterior skull base meningiomas. As you can see in this drawing, these are the kind of midline skull base meningioma that can be treated through the nose, as you see, from the olfactory groove down to the petroclival region. And this is the kind of craniectomy we can realize through the nose, and you see the transcranial perspective on the midline skull base. From our series, as you can see, we have treated more than 100 meningioma, and the vast majority is represented by tubercle macelle meningioma, which, as you know, are maybe the most difficult to treat along the midline skull base. The basic principle that we follow to remove this meningioma are the one fixed more than 25 years ago by Aminkas Amerik Karau. We have to use two nostrils, we have to do middle turbinectomy at least on one side, and we have to create a corridor wide enough to move properly the instruments to reach the cranial base. We also need the dedicated equipment, because the standard instrument used, for example, for pituitary surgery are not enough, and we need dedicated instrument. We can start from tubercle macelle meningioma, and you see the kind of a craniectomy we have to realize in front of the chiasm and in front of the pituitary gland to reach the suprasellar area. And this is the kind of view we have when we expose and remove the meningioma through the nose. You see, we have to realize a wide craniectomy above the cella, because we have to control the supraclanoid carotid artery, the ophthalmic artery on both sides, and we have to reach a wide exposure also on the anterior circulation to remove properly this tumor. So for this reason, the kind of craniectomy we have to realize needs to be, especially for meningioma, quite wide. So this is very important, because otherwise it's like when you remove a convexity meningioma with a smaller craniotomy. You cannot control the lateral border. So we have to resect properly the bone above the cell. This means that we have to reach our bone, we have to extend our bone removal up to the lateral OCR. This is a study in which we demonstrated that we can extend quite laterally our bone removal, including the anterior clinoid process. And to do that, it's critical during our bone removal, the exposure and the opening of the supraoptic recess. If we drill above the optic prominence, we can control widely the extension of the tumor into the optic canal. The principle, of course, of tumor removal are the same we apply when we remove the tumor transcranially. And the main benefit of this approach is that we early devascularize the tumor. We can perform an early debarking of the tumor, and if we expose properly our supracellular corridor, you see we can dissect the tumor from the vessel and from the nerves almost without touching this structure. You see, we manipulate mainly the tumor, and we do just a minimal manipulation on the optic nerve, chiasm, stalk, and so on. What kind of tumor we can remove through the nose? Of course, we can remove the smaller or the medium-sized one, like this one. It's if we expose properly, it's not so difficult at the end to remove this tumor, but we can remove even a larger one, like this one. And for example, you see this case that has been operated previously transcranially with quite a pure result, incomplete resection, and this patient has been then treated endonasally with the gross-total resection. This is another case. You see pre-op and post-op, and this is the typical neurovascular conflict we see in tuberculum cell meningioma. You see that in most of the cases we have a conflict with A1, which in some cases can really almost cut the nerves. So when we have such a severe neurovascular conflict, it's very important to manipulate the less is possible the nerve of the vessel. And if we see the results on tumor removal, you see that the results are quite good. But what is really good is the visual outcome. We controlled this patient and in our series, and you see that the visual field and the visual acuity improve in the vast majority of the patient. And the improvement is also present also on those patients which already had a severe visual function before the surgery. But of course, we cannot overcome the biology of the tumor or the extension of the tumor. And in cases like this one, which we have an extension of the tumor inside the canalicular part of the canal, even if we open all the canal, the optic canal, and we follow the tumor extension up to the annulus of Zinn, you see that when there is a true infiltration also of the meningeal layer, even if you decompress the entire canal, at the end, this patient will not improve so much. This just because you cannot change the biology of the tumor. And the same is for those cases in which you have encasement of a perforating vessel. In some cases, you still can have an arachnoid plane and you can dissect the tumor, but in other cases, you don't have any arachnoid plane. So in this case, maybe it's better to leave some remnant. When we look at the configuration of the sphenoid sinus, especially in tuberculum cell meningioma, you can see that there are cases in which the approach is more favorable and cases in which the transsphenoidal route is not favorable. And you see, for example, that when you have a deep cella, like in this case, it's much easier to expose the tumor than in case in which you have this angle. We have studied the different configuration of the sphenoid sinus in relation to the extension of the meningioma, and you see that there are good cases like this one, or even better cases like this one, and there are worse cases like this one. In this case, for sure, it's much easier and faster to remove this tumor transcranially than endonasally. So the best case to be removed endonasally are those with small or medium size, with deep cella, without vessel encasement, and without broad dural attachment, especially over the planum. And if we move then to the planum sphenoidale meningioma, of course, there are cases like this one, which are much easier to be treated transcranially. And the same when you have asymmetric extension over the planum. But when you start to see cases like this one, and we see, for example, cases in which you have a lot of edema and a calcification along the base, in a case like this one, we prefer to use endonasal corridor. And you can see the benefit of this approach because when you start the approach, the first thing you have is the removal, the vascularization, the removal of the calcification on the base. Then you can start the debarking of the tumor. The principles are always the same. And I just want to show you how the brain appears without any arachnoid plane. So without any manipulation on the brain, we can resect the tumor. You see, there is no arachnoid plane. We can devascularize the tumor and then remove completely. And how we reconstruct? We reconstruct mainly with the fat. We remove the tumor and we plug fat inside the defect. And then we cover the entire defect with the mucosa flap, harvest from the turbinate, from the nasal septum, and then we pack completely the sphenoid sinus. This is the nasoseptal flap, and this is how appear the surgical field after surgery. This is the big piece of fat we plug inside the cavity, and this is how it appears after some months. The fat is resorbed, and you see also the reduction of the edema of the brain without any manipulation of the brain itself. This is another case with a wide calcification along the base. Also, this patient has been treated before transcranially with poor result, and this is, you see the outcome, and then we operate endonasally. This is the fat across the skull base defect. This is the post-op visual field, and this is after 1 year. You see the fact that gradually resorbed and with the removal of the tumor. Then we can move to olfactory groove meningioma, which are, of course, the most controversial tumor treated through the nose. This is the kind of corridor we can create from one orbit to the other. These are some cases we have operated through the nose. So if you say we can remove it through the nose, yes, we can remove. This is the post-op MRI. But you see, we have to create really a wide corridor from one orbit to the other. And we skip the video. You see, you can remove, but then you have very large defect. And what is our policy now is to treat just selective olfactory groove meningioma, mainly those, of course, who are already completely anosmic, but mainly those that have already extension inside the nasal cavity. But otherwise, as I will show you, we prefer other approach. Also, we have to consider the extension of the tumor over the orbit, the facts involvement, vessel encasement. All these factors somewhere represent a contraindication for the endonasal route. And what we are doing now with olfactory groove. Of course, we prefer transcranial, but we like to do this with the exoscope. As you know, there are a variety of exoscope available on the market, and in our experience, there are some benefit in using the exoscope first, but not only the ergonomic of the exoscope, because when you use the exoscope, you can maintain the same position regardless to the approach. So it's the camera which is turned and not your spine. And also the deep focus you have when you use the exoscope, you are on focus on surface, and at the same time you can be on focus really into the depth. And the exoscope we use is this robotic one, which also has some benefit. You can control with the navigation. You can control with a second surgeon which move the camera so that you can operate without moving your hands from the surgical field. This is also the setup, which with the exoscope, it's quite nice because you can have all the instruments from the echo, navigation, exoscope, occlusa, whatever, in a sort of arch-shaped position. And we like to use, but the next speaker maybe will speak more into the detail. Just I want to show you how appear the tumor removal through interhemispheric approach with the exoscope. The principle are the same, but especially for a factory groove and on the planum, we really favor this approach because it's a midline approach for a midline lesion, and you can really have a nice view on the midline skull base. When the tumor is large, you can work on both sides of on the farts, and also the intradural corridor. It's quite short. This is just an example. Even when you have a larger tumor, and you see that the amount of manipulation of the brain is really reduced as compared to lateral approach. And when the tumor is smaller, you can even work just through a single side, a unilateral. And another benefit of this approach is that you can have an early control of the vessel. This is another case, and you see that you can have an early control of the vessel, so that you can start. Also, you have a short intradural corridor. You see here the separation of the tumor from the farts, and when the tumor is not so big, you can cut also a little bit the farts to control the extension of the tumor on the other side, and at the end reach the base and remove the last piece of the tumor. So moving to the conclusion, I want to say that the value of the endoscopic approach on midline skull base increase from olfactory groove, where really we can say that the indication are quite limited, and they increase gradually from the planum, and maybe the best benefit for the endonasal route is for olfactory, for tuberculum cell meningioma. And the contrary for the transcranial exoscopic approach, we realize that the best benefit are on olfactory groove and on some planum meningioma, where if compared to endonasal approach, the rule of a transcranial exoscopic approach is inferior as compared to the endoscopic endonasal one. This is the last slide, and I thank you for your attention.
Thank you, Professor Cavallo. So you are the impressive lecture. So you have nicely provided the detail of the endoscopic and exoscopic approaches for the anterior skull base meningioma. So Is there any question from the audience? So, okay, so first, I'd like to ask the question from our discussant. So, Professor Ashish Shukla, so please some the comment
Thank
or
you.
question. Okay.
Thank you, Professor Mori. Professor Cavallo, excellent lecture. Thank you so much. We were wondering in terms of the, especially for the young neurosurgeons, I think you have shown excellent pictures and demonstrations of the bony anatomy for how you select the patients for endoscopic approaches. Do you also look at the tumor consistencies on how they appear on T2? I saw that you showed a case where there was a significant edema, and then you did the surgery from the nose. But also looking at the tumor consistencies and its relationship with ICAs, like in terms of sometimes they are very medial or sometimes there is no medialization. Do you see any MRI characteristics for the tumors itself, which can help the young neurosurgeons to select their cases?
Thank you. Thank you for your question. And all the things you have considered are those we consider. We check on T2, we check any carotid involvement, we check the consistency, we check the optic canal invasion. All these things put together allow us to make the choice of the approach. Of course, you have to know that the bigger is the tumor, the higher is the consistency. And but this alone does not affect the choice. The mainly reason why we choose transcranial stent and the nasal is a vessel encasement. If we look for supraclanoid carotid complete encasement or ACOM A2 encasement, we prefer transcranial stent and the nasal. But the vast majority of tuberculous cell meningioma are without vessel encasement. So in the most of the case, and you can see from our series that the vast majority of the cases we treated are just tuberculous cell meningioma.
Great. And I saw that there were extensive, defects which you mentioned that can happen in these kind of surgeries. So what is your, the policy for repairing the dural skull base and CSF leaks rates in your own experience? How bad it is the CSF leak? Can you use lumbar drain afterwards or not?
It changed dramatically over the last 4 or 5 years because over the years we have used a lot of technique, a lot of material, and most of this failed, including lumbar drainage. The worst material you can use for reconstruction are the synthetic or the heterologous. So at the end, the technique we use is this 3F technique, which is made just by fat, periabdominal fat, big piece of fat. We put across the skull base the fat, because with fat you can seal all the border and you can avoid any compression on the structure. Then we cover the fat with the nasoseptal flap, which is autologous, which is vascularized. And then the third F is fast, which means early mobilization of the patient. Because if you leave the patient supine in the bed, it's very bad, because you have the transmitted pulsation of the brain over the skull base defect. So the day after surgery, we mobilize the patient from the bed, and when the patient are in the bed, we leave the patient in semi-sitting position, never supine. And we don't use lumbar drainage because it failed. We had a lot of cases in we have used it, and even with lumbar drainage, you can have CSF leak. But with this technique, the rate of CSF leak dramatically has been reduced.
So you'll use it like if suppose there is a leak post-op, how do you manage in your setup, in your experience?
Use fibrin glue injection at the patient bed. We have a mobile cart. We check with the endoscope through the nose. If we see that there is a small leakage, we just inject some fibrin glue into the spined sinus. And you can repeat these 2, 3, 4 times, and it works in the vast majority of the case. Of course, if you have a large CSF leak and the patient is symptomatic, you have to reoperate. But again, I want to say that with this technique, it's going to become more rare that you have to reoperate or you have to inject fibrin glue. This technique really seems to work well.
Thank you, Professor. Last question, like in terms of your transcranial approaches, we've seen the use of your exoscope. What are the cases where you will see you are more comfortable with microscope because exoscope is not available everywhere? But like, what are your indications where you will not use exoscope and you will only use microscope for transcranial approaches? Is there an indication or no?
Honestly, I have to say that since we have begun to use the exoscope, we almost are not using anymore the microscope. But
Microscope.
it's still there. It's still close to the OR. So it's a purely electronic device. It's not optical, it's digital. So you have to consider it's like the endoscope. It's a digital picture. So you have to rely on technology. So it's always, even if you start to use only exoscope, it's good to have and to know how to use the microscope because in case of trouble, you have to rely on the microscope.
Thank you so much, Professor Cavallo.
If I can ask one question.
Okay, please, Professor Raja, please.
Okay, Prof. Cavallo, first of all, thank you very much for this wonderful presentation. Just one question, what are your tips for preserving olfaction in olfactory group meningiomas?
I think it's like pituitary stalk in craniopharyngioma surgery. You can preserve anatomically, but you cannot preserve functionally. I mean, there are cases in which you have unilateral involvement, in which you have good arachnoid plate and you can try to dissect and you can preserve it. But there are cases in which, at least in my experience, you try to preserve anatomically, but then you lose functionally. So if you have arachnoid plane, try to dissect and preserve, but the functional result is not guaranteed.
Okay, thank you very much.
Okay, so Professor Cavallo, so I have one question. Can I ask the?
Yes, of course.
Okay. Yeah, so how about the indication of the combined surgery? So endoscopic and transcranial surgery. So in some cases, the patient severely deteriorate the visual function and the tumor, some meningioma, invaded the optic canal invasion, the superior and the medial and the inferior. So in such a situation, we usually selected the combined approach. So how about your opinion?
Yes, you can do in the same session, and it's the same setting we use, for example, for some pituitary tumors or for some anterior skull base malignancies. You can do on the same stage with two teams, one working to the nose and the other transcranial, but on the same stage.
Okay, so thank you for the presentation. So we will move the next the presentation. So the next speaker is Professor Ngo. So his topic is interhemispheric approaches. So the Professor Ngo. So let's start with your lecture.
Please unmute your mic, Prof. We cannot hear you. Your mic is still muted. Yeah, okay.
I think you can see my screen.
Yes.
Yeah. I would like to thank organizing committee and to Professor Cotto and all members. I will talk about the interhemispheric approach. and I have nothing to declare. I am lucky because I learned microsurgical anatomy from Professor Roton, and I had the chance to work with the Professor Yaşargil, and I'm still working with him. And we published several papers about the white matter tracts of the cerebrum and the interhemispheric approach you can find from websites. Why we are using the interhemispheric approach? Because as we know, the lateral surface is richer than the medial surface with white matter tracts and important white matter tracts. Because of this, we always try to use interhemispheric fissure or the Sylvian fissure or supracerebellar way. And as you see, if you go from the lateral surface, you will have the arcuate fasciculus and the optic graduation and SLF fasciculus. But if you use the interhemispheric way, you will encounter with the also only callosal fibers. And most of the case, you won't have any deficits. What are the issues during the interhemispheric approach? One of the most challenging issue is the bridging veins. This is for example, this is the interhemispheric approach. You can see the vein. You always must protect all bridging veins because you couldn't know what will happen after sacrificing any vein. Mostly after sacrificing veins, the patients may have seizures and the venous hematoma. Because of this, you should have protect the all bridging veins. As you see, we work the both sides of the vein without sacrificing. And also during the craniotomy, before the craniotomy, you can select your craniotomy size to preserve the venous anatomy. As you see, you can change your craniotomy before the operation. You can have MR venography or contrast enhanced MRIs. As you see, if you have a bridging veins like this, you can have a craniotomy like this. And depends on the location of the veins, you can change the location of the craniotomy to preserve these veins. But, sorry. If you couldn't check before the operation, for example, there's a vein we try to protect, and we want to select one side to enter the interhemispheric fissure, and we cut the dura just behind the venous structures, while preserving its drainage. You can see with Doppler ultrasound, we check its drainage and cut behind preserving the veins and continue to the operation. This is this was a thalamic tumor. I want to preserve the venous drainage. This is the postoperative view. You can see the vein. We only work in this area. And lastly, we published an article about the cunose vein and its preservation technique. In posterior interhemispheric way, you can encounter with the vein which is directly goes to the falx, not the superior sagittal sinus, and you must preserve it. This is our preservation technique. As you see, we can cut the falx and release the release this vein and continue our operation. Because of this, the preoperative imagings and the know all veins, venous anatomy and arterial anatomy always important. And then there are some challenging areas in neurosurgical practice. One of these is the arterial lesions. As you see, there's the arterial lesions. It's the cavanoma, and mostly lateral approaches are used to reach this area. But as you see, the optic radiation and also arcuate fasciculus located the lateral to this area, especially in the dominant hemisphere. But if you go from the medial surface, you will only cut a part of the forceps major and go directly to the atrium. And there is a meningioma case. It is approach via lateral approach, transsulcal lateral approach. Even you use sulci and without disrupt any white matter tracts, the patient will have visual deficits. Because of this, Rashagil also described the posterior interhemispheric transpericuneal approach to use to reach the atrial region. With Professor Ture, we described using the parieto-occipital fissure, like the Sylvian fissure. You can open this fissure and directly reach the atrium without entering the precuneus. As you see, after opening the parieto-occipital fissure, you can reach the atrium and can remove the tumors. This is the medial view, and this is lateral view. The atrium is opened, and you can see the light of the endoscope. And you must know the anatomy of the medial surface if you want to reach interhemispherically. This is the parieto-occipital fissure, as you see here. And after opening the interhemispheric fissure, you can describe the parieto-occipital fissure and just under the parieto-occipital vein. And with ultrasound, you can check the anatomy, as you see. And in our operation, we use the cotton-guided surgery, ultrasound, with using ultrasound. We put a cotonoid and check with the ultrasound, and this is cavanoma, this is our cotonoid, and this is cavanoma, and after removal. As you see, this is the preoperative and postoperative view with preserving the all optic tracts and the simulum fibers. You can enter the atrium and remove this kind of tumor. Even the lesions are big, you can use interhemispheric approach. You can think there's a short way to do atrium and reach the lesions, but all these tracts are cut and the optic radiation located lateral to the lesions. As you see, we could reach and remove all tumor with the interhemispheric way, and also you can see this it came thicker tissue after removing the tumor with preserving the visual area. And one of the challenging areas is the motor area, deep motor area. As you see, this is the cortical spinal tract and the motor area. This is the functional MRI combined with the MR tractography, and the lesion is located. If you want to go from the lateral surface, you must have some deficits. Also, in the literature, they say most of the cases, at least 50% of these cases located in the deep motor area can have deficits. But we think that the motor area finished as the cingulate sulcus, and if we use the cingulate sulcus, we can reach these deep area with preserving the motor functions. As you see, there's a deep sulcus in the medial surface, and for lesions located medial to the corticospinal tract, you can use this approach and remove this kind of tumors. We know that there's a long way, and also it is difficult to turn laterally, but we did the similar thing with the posterior interhemispheric transparent occipital fissure approach, and we decide to do this approach. First described in the laboratory, then in the operation. There's a patient with multiple carcinoma. Interhemispherically, we dissect all interhemispheric fissure, then find the singular sulcus and dissect the singular sulcus. As you see, this is the singular sulcus, this is the marginal ramus of the singular sulcus. We dissect all these sulcus to the deep. And after the dissecting all sulcus, we enter deep of the sulcus and find the tumor. You can use the navigation and the ultrasound. I prefer always ultrasound because it is real-time navigation, and can remove the tumor with preserving the motor areas. This is the postoperative view with also preserving all venous anatomy. This is preoperative, and the postoperative view. We use these sulcus to reach and remove this area. This is the postoperative view. Also, you can reach other kind of glial tumors like GBM, also low-grade gliomas, and also colloid cysts, which are located the third ventricle. You can reach the interhemispheric transcallosal approach. Firstly, you must know the anatomy of the ventricles and the third ventricle. And during the operation, we use a smaller opening, but always change our microscope angle during the operation. And you can use the navigation and ultrasound to select your callosotomy area. And these are the preoperative and the postoperative view. You can see 3 millimeter or callosal opening may be enough to reach and remove this kind of tumor. This is the early postoperative and late postoperative MOS. You can see the small opening of the corpus callosum. I will show a video of one of our cases. I always use a lateral approach to use gravity, and I don't use any retractor during operation. Also, for posterior interhemispheric approach, I use a prone oblique approach. This is the ultrasound. After opening the craniotomy, I use ultrasound to select our duotomy. As you see, I think there's a 2 or 2.5 dual opening. I'm first opening the arachnoid to release CSF, then go interhemispherically and find the pericallosal arteries. And we always use the to open corpus callosum between the both pericallosal arteries. And after finding the corpus callosum, we use a cotonoid guided ultrasonography and select our collosotomy area. And after opening our collosotomy, we dissect the cyst from the surrounding tissues. and remove. This is, and most of the case, I always do a third ventriculostomy to prevent the postoperative hydrocephalus. I don't use any extraventricular drainage system after operation. This is the postoperative view. You can see the carlosotomy area, with minimal opening. You can remove maybe more than 2 centimeter carlosis. Also, for some kind of craniopharyngiomas, for intraventricular ones, you can reach the posterior interhemispheric transcallosal approach using the foramen mono. Also, you can open the choroidal fissure, but mostly in the hydrocephalic cases, the foramen mono is enough to remove. You can see the enlarged foramen mono. You can reach and remove the tumor to use only using the foramen mono. This is the postoperative view. The total removal of the craniopharyngiomas. And also for deep-seated lesions like the thalamus, globus pallidus, you can use the interhemispheric approach. As I said, I am using the lateral position to use gravity. This is the after opening the corpus callosum. For this case, we use the anterior limb of internal capsule to reach the tumor. As you see, we use neuronavigation and neuromonitoring to reach and remove the tumor. This was the pleocytic osteostoma. And this is the preoperative and early postoperative and late postoperative MRIs. Previously, I used always ipsilateral approach, but nowadays I am using for deep-seated thalamic or globus pallidus tumors. I use the contralateral approach because it is easier to reach the lateral area from the contralateral side. I will show a video. This was a recent case of mine. You can see the deep-seated, also the cerebral peduncles to the cerebral peduncles. We use the open a callosotomy, then reach the tumor. You can see our trajectory to reach and remove these tumors. This is a right-sided tumor. We open a left-sided craniotomy, and we came from here and remove the tumor with anterior transcallosal way. And also for some cases, for example, poor aqueduct tumors, you can use the extreme anterior interhemispheric transcallosal approach to reach these kind of lesions. And also for pineal regions tumors like meningiomas and other areas, you can reach the posterior interhemispheric way. As I said, I always using the lateral approach and release CSF, but in this kind of tumors, it is difficult to release CSF because there's no cystine, because all cystines are full fit with the tumor. And after removing the tumor, I will show you some things. We open the, as like I did in the interhemispheric way. I opened the I did a third ventriculostomy to prevent the postoperative hydrocephalus. You can see this is the tuberosum, and I will open the tuberosum. You will see flow of the CSF. And also you can reach a medial surface or singular gyrus tumors. For example, I use a contralateral approach for these tumors because the patient has another tumor in the Broca area. After opening the fault, you can reach the tumor and remove. Then we remove the tumor located in the area. This is the postoperative, which a contralateral approach to the medial surface of the frontal and cingulate gyrus, and remove the transilvian approach to remove the Broca area tumor. And also for vascular lesions, you can, which are located the medial surface or the pericardial arteries aneurysms, you can use the anterior and the all interhemispheric approach. For example, this is the area located the medial surface of the frontal lobe. We use any kind of technology instrument to help us. And for this case, for medially located AVMs, you must find firstly the feeding arteries, as like all AVM types. And after opening the dura, we are going to interhemispheric way. And using the Doppler ultrasound to check the flow of the AVMs, and I am putting the temporal clips to arteries, which I think as the feeding arteries. Then check Doppler ultrasound again, and the flow is decreased. I coagulate these arteries and remove the AVMs. This is the postoperative view, postoperative ultrasound, and postoperative angiography, and the postoperative MRI. And also posterior interhemispheric way can be used for posterior medially located AVMs. This is the posterior interhemispheric approach. We describe the feeding arteries, then use the Doppler ultrasound and put temporal clips. Then check again the flow of the AVMs. Then remove the AVM. And what is the most lateral part you can reach via the interhemispheric approach? This is the insular tumor, but the patient which already operated via the thalamic tumors, but the patients had a recurrent tumor in the insula. We want to check the thalamic area first, then reach the insula. As you see, with interhemispheric way, we can reach the lateral part of the insula and can remove the tumor. What is the last, most lateral region to reach via the interhemispheric way? Why we use the interhemispheric way? To protect the important white matter tracts. As you see, there was a cavernoma located just lateral to the atrial part. The optic radiation located lateral to the it. Because of this, we resect these tumors interhemispherically. And for young neurosurgeons, whenever you want, you can visit our laboratory. We accept fellows from all around the world. And also you can join the operation of Professor Ture. This is the last photo of Professor Reşag, last visit. And also you can reach all our models from our website. I want to thank all to all my colleagues and mentors. Thanks for listening.
Thank you, Professor Ungo. So you are variable the presentation based on the your extensive experiences. So the is there any question from the audience or? So the first Professor Ashish Kumar. So please make
Thank you.
the question or comment. Okay.
Thank you, Professor Mori. Professor Babar, very eloquent and very deep-seated lesions you have taken out from interhemispheric approach. I was about to ask the position, but you already mentioned your lecture that you use the gravity and you always operate these on lateral positions. I also wanted to ask, like in terms of how much lateral you can reach through interhemispheric approach, because I think if the tumor is extremely like in some cases it was very lateral, right? So I know that we are like especially in the anterior third of the interhemispheric approaches, coming through lateral transcortical approach is also very well described. How do you choose why not to choose, for example, to come for through the middle frontal gyrus anteriorly versus trying to come through an interhemispheric approach, and the lateral extent of the tumor, and it also depends on the size, of course. But if it is big and it's lateral, why not to come from the middle frontal approach, middle frontal gyrus, like transcortical approach, like usual situations? How do you decide like which one to choose?
We use also most of the case we use our knowledge of the white method anatomy, because we don't want to disturb any part of the arcuate fasciculus, for example, in the middle frontal gyrus. And on the posterior side, we try to protect the optic graduation. If we think there's a risk about the arcuate fasciculus and any kind of white method thorax, we try to use the interhemispheric approach. And for example, for ventricular tumors, interventricular tumors, I showed some interventricular tumors, laterally extent tumors. Most of the time, the attendees, they ask why we don't use the lateral approach, because the thorax are there, but a bit compressed, not gone anywhere. For interventricular tumors, when you cut the feeding arteries, like because most they come from the choroidal arteries, when you go the interhemispherically, you firstly polarize and cut the feeding artery and try and start to remove tumors. When you remove, you can the tumor can come from lateral to the medial with after debulking, and or you can remove any kind of any size of tumors, interventricular tumors, with this approach. For medially located tumors, for frontal approach, I always use interhemispheric way. Some neurosurgeons say interhemispheric approach is a bit dangerous because of the bridging bridging veins and also pericallosal arteries. But I also try to show some techniques to preserve all these veins and the arteries. We don't have the complications with the bridging veins and the pericallosal arteries because we always try to preserve. Sometimes we spend more than 1 hour to preserve one vein to dissect from its arachnoid from the cerebral surface and from the dura. But always we try to preserve any veins and arteries.
Professor, what is the incidence of supplementary motor area syndrome, especially when you are doing interhemispheric? That's the most, and if there's a bigger tumor, you are retracting medially more. I know even if it is deep, but still there is subretraction. So what's the SMA syndrome risks in your experience?
Because of the retraction or?
Yeah, because of like it's in anterior third, if you're in the motor in the premotor area and you have to go like ipsilaterally on the same side, there's bound to have some retraction. So what is your assessment of SMA?
Maybe I showed some videos, and I always use the how can I say, the falx side to enter to. I always try to not to touch the brain. I always working from the falxian side. And if you don't retract these areas, any cortical areas, I think you don't have this kind of deficits or syndromes.
Then last question, do you think that the depth of your approach becomes a disadvantage for example, if you're trying to do a ventriculostomy through microscope or, you're not using the endoscope, I assume, for third ventriculostomy?
Also, I use for example, I use endoscope to check, not the full endoscopic surgery. Because for endoscopic, poor endoscopic surgeries, you must go through the cortical area and disturb some cortical and white matter tracts. Because of this, we are always try to use the interhemispheric way and open a small callosotomy. Yes, it is a long way. Maybe I showed a case from the one of my last cases. I think from the skull to the last part of the tumor, maybe more than 10 centimeters, 10 or 11 centimeters. You must have some long instruments, and know the anatomy. Without knowing the anatomy, you couldn't. How can I say? You couldn't. Find the tumor and recognize which structures. For young neurosurgeons, firstly, you must go laboratory and learn all anatomy, then try to reach these areas.
Yeah, and third ventriculostomy, you like when you're doing a third ventriculostomy in your interhemispheric approach, you don't use endoscope assistance to do that
No.
You just use microscope.
Maybe it takes maybe 10 seconds for me, 5 seconds to open open the tenacious. I see and open with the bipolar.
Microscope.
Yeah, it takes 5 or 10 seconds only.
Thank you so much, Professor. Amazing cases.
Okay, so next, Professor Roger, please make some comment.
Yes, first of all, let me thank Prof. Gungor for showing us these beautiful surgeries. I just love the way you dissect the veins. You said you dissect around 1 hour to free veins. So that is exactly what microneurosurgery is all about. So the dissection of interhemispheric veins, the Sujita Kobayashi maneuver was described in the JNS in 1982. One of the beautiful techniques, you go around with a cuff of arachnoid right into the superior sagittal sinus. That's a beautiful way, and I presume you are also doing the same way. But I understand it is unpardonable to sacrifice a vein in the posterior hemispheric interhemispheric, but in the anterior interhemispheric region lesions, you have redundancy of a few veins. You can get away with the sacrifice of 1 or 2 veins in the extreme anterior interhemispheric approach. When you are doing it for an aneurysm, for example, you have to go subfrontal and interhemispheric. So we have done a few cases.
Because
what
I
is your
never
opinion?
I never sacrifice any veins because I am lucky because I started to operate this kind of tumors after Professor Ture, after working with him. And also during my residency, I saw any kind of complications after venous sacrification. Most of them, the patients, after operation, the patients was good, but 2 days later, the patients start to have seizures, uncontrollable seizures, and we saw venous hematoma. It can be small or big, but I think one of the most epileptogenic areas of the venous hematomas. Because of this, even the bridging veins can be small, maybe located anteriorly. It's the best way to preserve, because you couldn't know what will happen.
Yes, of course, I understand that there is no better way than to preserve it. That should be the goal. But if at all in the extreme anterior hemisphere you have a bit of I must say luck, maybe we don't know.
Yeah, I think the patients with the why it described as a safe to sacrifice the anteriorly located bridging veins, because the frontal area is a most safe area. If you remove, or if there's a hematoma or a venous infection, patients won't have any motor deficits. Because of this, it can be seen. It was seen as a safe area to sacrificing veins. But for young surgeons,
yeah, I understand. The teaching is preserve at any cost. I understand. Thank you very much.
Okay, thank you. So Professor Koko, so I have one question. So I completely agree with you about the contralateral approach. What is the most important factor to consider the contralateral interhemispheric approach? So please mention some of the comment.
Yes, if the lesions, I think for contralateral approach, you can use, for example, as I showed, the medially located low-grade gliomas, and also you can reach from the ipsilateral approach. The advantage of the ipsilateral approach, if you have some problems during the interhemispheric approach, you can go transcortically. I never experienced that, but if there's a problem during the interhemispheric approach, swallowing or something, for edema, because of edema, maybe you couldn't use the interhemispheric approach. You can reach transcortical approach to remove this kind of tumors. But for example, like deep-seated thalamic tumors, for the thalamic tumors, if it goes a bit laterally, the contralateral approach always has some advantage to reach the contralateral lateral surface. But some neurosurgeons always use wide side because of the dominancy, because of the using the non-dominant hemisphere. Because if there's a complications, any complication, venous or arterial complications, the patients can have less deficits. But I can use the left or right. I don't think about the dominancy, because I always I always preserving any veins or anything. As I said, for thalamic tumors or medial tumors, you can reach contralateral approach, but the midline located lesions, you can use a wide side, but maybe you can check the venous anatomy to select the craniotomy side, but mostly wide side is preferable.
Okay, thank you for your additional comment. Yes. So is there any other question or comment from the audience? Okay, so we will move to the next presentation. So the third presentation is Professor Mori. Yeah.
Yeah, I'll present it from my side. Prof.
Okay,
Mori,
so
can
yes.
unmute your mic, please.
Thank you very much, Dr. Morisako. I specialize in gamma knife radiosurgery. I appreciate this opportunity. Today, I review the radiosurgery for skull base meningiomas. Next slide. Okay. Our goal is not just controlling the tumor, but protecting function. We preserve function in about 78% at 5 years. Yet we must respect those limits. 10 gray for the optic nerve, 12.5 gray for the brainstem. And surgery alone has a high risk 50%. Also, recurrence after subtotal resection is a challenge. So integrating radiosurgery is essential. Next, please. Since 15 publications have increased with ICON system. Gamma knife radiosurgery achieved around 96% control at 5 years, which is excellent and provides stable outcomes. However, a key limitation is that most data remains retrospective without randomized trials. Next. The ICON system changes our practice and enable fractionation radiosurgery. We've safely treated larger and more complex tumors, even near critical structures, using the planning application Lightning and mask system fraction is fraction. In our institute, we installed the ICON system in 2019. We can now safely treat more complex cases, a frame and non-frame system. Next, please. Yes. Do we wait or do we treat early? Studies show 66% growth within 4 years. Early intervention may preserve neurological function. Thus, upfront radiosurgery emerged. We treat tumors while they are small, before symptom. After surgery, once imaging stabilizes, we proceed early. Please, next slide. we don't fractionate because the tumor itself sensitive. We use fractionation to protect normal tissues while maintaining control. Control is about 95%, and complication dropped from about 60 to 6%. Even before icon system, we used staged radiosurgery with frame-based fixation. We always aim to protect the brain. And next, please. I'll show fractionation works. Single session for 12 to 14 gray and fraction 7 gray 3 times. Meningiomas, low alpha beta ratio 3 gray, but not sensitive to fractions. Next, please. I show 2 cases. One on the left, the tumor is for the optic chiasm, so single fraction radiosurgery is safe and simple. On the right, the tumor is near the optic nerve and brainstem. One fraction will be risky, so we use hypofractionation. Next, please. Dural tail sign management is challenging. The question is simple, include it or not. Histology shows tumor infiltration in some cases, so including the tail can be reasonable. It may reduce recurrence, but we have those considerations. Especially near critical structures, we can't always include a full tail. So there is no single correct answer. We decide on case by case. Next, please. Interesting. Even among experts, there is variation. We studied this in the Kansai Gamma Knife Consortium. We compared PTB contours from the same case across 5 centers. The difference was striking. Some include the dual tail aggressively. Green line. Others limit the target to protect critical structures like the pituitary gland, blue line contouring. The strategy also varies. Some use single fractions, others use hypofractionations. As a result, the target volume ranged from 3.3 to over 9 cc. For the same cases, this is the key point. Radiosurgery is not only physics, it is also a clinical judgment. Next, please. Next, radiation-induced optic neuropathy, RION. This defines out our limit. The limit is optic pathway. 8 gray is safe. Limit RION is rare, 1 to 5%, but devastating. It can change a patient's life, so does matter. This is where fractionation is critical. It helps us stay within safe limits while treating the tumor. Safety is a top priority. Next, please. Short-term results are excellent, but long-term risk exists radiosurgery. For example, vascular complications occur in 2 to 5%. This includes arterial occlusion for stenosis over time. Peritumoral edema can also increase even years later. We may also see unexpected effects as the tumor shrinks, adhesions can form. This can lead to trigeminal neuralgia. So the message is clear. Long-term follow-up is essential. Next, please. After surgery, contouring is difficult. On MRI, post-operative changes can hide the true margins. So timing is critical. We also need to understand the surgical intent. What was removed and what was intentionally left behind. Close communication with the surgeon is essential. The surgical record is as important as an MRI. In this case, part of the tumor was attached to the brainstem. It was intentionally left to avoid injury. So we use a hypofractionation. There's five fractions. 2 years later, post-operative state. Post-gamma knife, 5-year follow-up, the patient remains stable. Tumor not shrink, same volume. Next, please. Surgery and gamma knife are complementary. The support is each other. We integrate them. Surgery reduced the mass. Gamma knife ensures control. This is our strategy for skull base meningiomas. Our goal is clear: preserve function and maximum quality of life. Next, please. In the past, large tumors were challenging to rest. Radiosurgery was often limited by volumes. However, this has changed. Single fraction is 8 cc limit, but fraction recent studies show that it can now treat large tumors. They treated volumes up to around 28.9 cc. Even at this size, they can maintain excellent control. The control rate remains approximately 95%. That said, we still have work to do. The optimal fractionation schedule remains an open question. Which schedule is best? 3 fractions, 5 fractions, 10 fractions? We still need more evidence. Next, please. Finally, a fundamental point. Histology defines our strategy. Not all tumors are the same. Grade 1 tumors have excellent outcome. Results are usually stable. Grade 2 tumors are different. They are more unpredictable. we must especially careful with SFT HPC, follicular fibrous tumor, hemangiopericytoma. These are more aggressive, no controlled. In the end, biology matters. We treat the patient, but we must respect tumor biology. Next, please. Last slide. To summarize, radiosurgery, timing matters, and planning control is critical. Procrastination expands our opinions. Histology matters. Ultimately, we choose the right strategy for each patient. It's not just the machine, it's our clinical judgment. Thank you very much for your attention.
Thank you, Professor Mori. So you had a wonderful lecture. So Professor Mori showed the important treatment strategy, including some of the limitation of the common knife. So is there any question or comment? So Professor Ashish, please make some comment.
Thank you, Professor Mori Sako. Professor Mori, great lecture. Thank you so much. I just wanted to ask if there's a different strategy for cavernous sinus meningiomas, because those are the cases where you'll expect sometimes based on the radiology, many surgeons would prefer direct radiosurgery because to prevent the cranial nerve deficits. So in terms of the response rates from radiosurgery for cavernous sinus meningiomas, because I think that's a little bit tough for surgical approach, especially if you want to preserve all the eye functions. So if you are doing it for cavernous sinus meningiomas, what is your what is your experience? How it responds to it, and like if you have a similar experience in cavernous sinus meningiomas.
Thank you for question. And for cavernous sinus meningiomas, we often prefer upfront radiosurgery. Tumor control is so excellent, around about 90%, and cranial nerve function is well preserved, but high dose cranial nerves the function down. We prefer upfront radiosurgery nerve function preserved.
Okay. Thank you so much. And do you have any experience of radionecrosis in the brain, surrounding brain, in skull-based tumors? I know it's very rare because these are not intraaxial tumors, but any risk of or any experience like with radiation necrosis in the adjacent brain when we are doing it close to the brain surfaces of parenchyma?
My experience, skull-based meningioma is not radiation necrosis, but hemangiopericytoma radiation necrosis around brain,
Yes.
around tumor.
Thank you. Thank you, Professor.
Okay, so next, Professor Raju. So
Yeah, thank you.
Yeah.
Thank you, Prof. Mori, for this beautiful presentation. Regarding the extension of what Prof. Ashish asked, I would like to bring to your attention the ACNS task force, which had an article published recently regarding SRS for meningiomas, and they said that SRS or SRT should be considered in cases where the patient is asymptomatic, more than 40 years of age, and intracavernous sinus meningioma less than 2.5 centimeters, which shows a serial growth on a initial conservative treatment. And also in symptomatic patients with cavernous sinus meningioma less than 2.5 centimeter, provided that the symptoms are not related to optic nerve compression. So this is a beautiful paper. There is a lot more, but I just wanted to bring into your attention. So in your cases where there is any visual compromise, would you still advise SRS for such patients?
We first consider surgical decompression after the radial tumor use radiosurgery and developing surgery tumor.
Understood. Thank you.
Okay, thank you, Rajesh. So I have some questions. So I'm very interested in the upfront the gamma knife for the case of the meningioma. So you mentioned the cavernous sinus meningioma is very good indication for the upfront. So is there any limitation of the size of the tumor for the upfront gamma knife therapy? So I have one question. So
very upfront, not so radiation is not tumors small, very small, and not attached now.
Okay, so if the tumor, the volume is very small, so
yes,
the upfront gamma knife is sometimes indication. But if the tumor is large and compressed vital structure, maybe surgery is the first option for such a kind of patient. Okay, thank you very much. Okay. Is there any question or additional comment?
None so far.
Okay, so Rajab, please go ahead.
Prof. Ashish, any comments from you? And close.
No, this was a great, all three lectures were very insightful in my opinion and covered different aspects. I think all those who are interested in skull-based and neuro-oncology will be very happy today because of this wealth of information shared by all the three speakers. Thank you so much.
Thank you. We can have concluding remarks from Prof. Kato. Please unmute.
Okay.
Fine.
Can you hear? So
yes.
Thank you so much, the three speakers. Dr. Cavallo, thank you very much for your nice presentation, and also that you switched to the microscope, so maybe exoscope. So maybe once you learn more experience about exoscope, maybe please teach us again. Thank you so much. And also the Gunger, your talk is always combined with anatomy. So many cases, even interhemispheric approach, we learned so many cases.
Thank you, Professor.
Yes, with that approach, we can do the surgery. Thank you so much. And also, Mori Sensei, thank you very much.
Thank you
very much. Interested in the trigeminal neuralgia because our institute is pure endoscopic the treatment for trigeminal neuralgia. So maybe some mechanism is I want to learn from you, but maybe next time. I think in Japan, the aged people is increasing very rapidly, and also less invasive the era we have now. So I think radiosurgery is getting busier. easier in your life, I think. Anyway, thank you so much. It was very useful webinar. Thank you very much, Dr. Rajan.
So thank you very much all the honorable chair speakers and Prof. Kato for joining today. We will continue this skull base webinar again in future and hope to see you all again.